Welcome to The Pursuit of Health, the podcast on health policy for a free and modern society. Welcome, everyone, to another episode of The Pursuit of Health. I'm your host, Reinier Schuur, and joining us back on the show is Jared Rhoads. Welcome back, Jared.
Welcome. Good to be back.
So what we're going to be doing today is we're bringing together two topics that we've both worked on, physician-owned hospitals and cross-subsidization. And the way that I got into relating these two topics is that I've done a series of articles now on physician-owned hospitals. And this argument that I kept seeing popping up against physician-owned hospitals and for maintaining the ban on them under the Affordable Care Act, in particular from receiving Medicare and Medicaid dollars, is that traditional hospitals can't compete against them, essentially, is saying that they're a threat to traditional hospitals' bottom line. If they have to compete with physician-owned hospitals who can maybe more easily choose their patients, whereas traditional hospitals often have to accept whoever they get. They often can't refuse them. That then they can't stay in business. And I always thought that struck me as kind of a strange argument, because you don't hear that argument in any other industry, where if people say, well, we can't compete, well, that doesn't automatically mean that, okay, well, therefore we have to stop any kind of competition. So I wanted to take the opportunity in this episode to kind of understand that argument and if it really has any basis. But before we do that, how about you explain to our audience, Jared, where this kind of argument comes from hospitals?
So in particular, the cross-subsidization kind of component of it, that's something I wrote about in a couple of, maybe it's a couple of months ago now. It appeared in Law and Liberty, but we also have it on our website. And probably the easiest way to get it is to go to the centerformodernhealth.org website and scroll down a little bit, and you'll see it, and you can get the full text. But the issue of cross-subsidization, as I analyzed it in that piece, is not so much the one about private payers paying more for care and services, and then and hospitals kind of making a profit on that, but then sort of losing money on other payers like Medicaid, and maybe like kind of breaking even on Medicare. Oftentimes that's sort of the how that issue is described. There is that kind of cross-subsidization as a whole issue. I mean, maybe we can talk about that a little bit, but the article that I wrote a little while ago was actually kind of revealing and kind of just bringing to light the other kind of cross-subsidization that happens in hospitals a lot, which is between different departments and different service lines. There are a lot of, kind of ortho surgeries that are very, very profitable to do for various reasons. And then, the classic, kind of example of a service that you often lose money on. You're not getting the payments and the reimbursements to really cover your costs, or something like the emergency department, emergency care. Psychiatry is sometimes put in that bucket. Pediatrics can be in that bucket as well. And so what you have is a situation where hospitals are sort of making an unusually, economists might call them non-normal. Like normal has a special meaning in economics. So they would call it a non-normal level of profit in one area, and then like taking a loss in another area. And what kind of ordinary business does this? You don't go to a restaurant and and have the people in the back like hoping you order this because it'll make them a huge profit, and fearing that you'll order that dish instead because that they sell that at a loss. Like, they just don't do that. They sort of price everything. They build in a little bit of a profit into everything. It's it's not exactly even all around, but it's they don't do some things at a massive loss in order to kind of balance out other things that they're doing at a profit, or vice versa. And so that's kind of what that article is about. And one of the things that I talk about in that article is how that that whole situation gets used as sort of cover or an excuse for hold, kind of fending off competition. And if you have to defend a certificate of need law that you've been the sort of incumbent and the beneficiary of as a hospital, you submitted the paperwork and went through the process to get your hospital to get the fancy piece of equipment or the extra wing of with the additional beds. You've gone through that process, but now you want to keep your competitors out, and so you in a very sort of narrowly minded way, you kind of defend the certificate of need law infrastructure. You might use this excuse of cross subsidization, like, oh well, we can't afford to have this profitable service line diminished because we need to have that extra profit to prop up and sort of keep open our emergency department, right? And that's our reasoning now for keeping competition at bay. And I think it's just for many reasons it's a bad situation to be in. Sort of forces everybody to kind of be a bit dishonest about what's really going on. About it masks real pricing and price signals from happening, and not to mention it just like keeps out the actual competition, which would be a very productive thing. So that's a number of reasons why this is kind of a bad thing, and I wanted to kind of bring that to light. And I think it comes up in this physician-owned hospitals issue quite a bit too. And so it's good to sort of extend that and apply that kind of view and framework to this issue now.
And what I find interesting is that I often see defenders of physician-owned hospitals and people who make the case that we should repeal the ban on them under the ACA kind of accepting the broader framework around this argument, but then basically saying, okay, yes, you have to use some profits to cover unprofitable services, but a POH won't actually mean that you have to shut down certain services, and they'll like point to data where, well, they'll just get the money elsewhere, or like the impact will be minimal. And I find that a strange kind of argument, because POHs in that sense kind of like have to make themselves like seem small and be like, we're not going to be too disruptive, right? And it's like, that's again kind of strange, because then on the other hand, well, if they're not disruptive enough, why take the risk of lifting the ban, right? And it's like they kind of have to walk this like tightrope where they say, we'll be just disruptive enough to justify being let into the market, but not disruptive enough that like, okay, well, we won't actually like destabilize hospital financing. And I found that interesting, because no one really questions whether it's the hospital financing that is the source of the destabilization, right? And so let's get into that. Like, why is it that hospitals do this? Like, most businesses don't do this. Let's get into the kind of structural reasons, kind of why they have to do this.
Yeah, you mean why do they have to the cross subsidization, like having well, they're serving different payers. That's one reason. On the one hand,
and they have to, right?
Yeah, right. Yeah, in some cases there are laws. There's EMTALA, for instance, that the Emergency Medical Treatment and Active Labor Act that requires you to it places certain burdens on you to relative to your emergency department and who you can treat and who you need to treat, and what level of treatment you have to give them before you can do anything further with them, right? And just how you have to interact with them. And different payers too, being at different levels, right? You have Medicaid, that Medicaid, Medicare, you've got CHIP, all of these programs that aren't paying a market rate on things. And by market rate, I don't merely mean an amount of money that's the same as a market would maybe arrive at, because really market is a process, and I think that's an important thing to mention here. Like, they're not using a number that for various reimbursements rates on services and care that they provide. They're not using a rate that is arrived at by a market process. So even if some of them are kind of on target, but that others aren't going to be on target because it's not a process that's arrived at because you have bidders on one side and suppliers on the other side, and it's economics 101 where the lines cross and everything. It's and so because they often feel like, well, we're required to provide some care at either completely uncompensated or just undercompensated, right? Undercompensated might be the term to use for like Medicaid patients that you're seeing. Medicare is a bit of a different animal. Some of those, I think on average, the general feeling is, I don't know the latest empirics on this, but I think the general feeling out there is that that Medicare maybe on average kind of reimburses you at roughly at cost, and there being some things that you make a profit on, and some things that you kind of take a loss at. You're asked to provide at below cost, and then the private payers are where you have the opportunity, especially depending on the market and depending on what kind of negotiating power you have relative to the insurers in the particular geographic part of the country that you're operating in. You might be able to extract a higher than normal profit with them, which then you use to justify again these other kinds of services and care that you're providing. And so it's this model, it's very distorting. There's differences in like who recognizes it, I think, and the extent to which they sort of accept it or not. There are some people, I think if you talk to people who work in hospitals, I think they recognize that it's happening, generally speaking. I'm talking about like people who are delivering care, but not active, politically or in policy circles. They're just sort of they're focused on just doing a good job of delivering care. I think they know that this is going on. If you ask me, like, do they accept it or do they approve of it? I don't know if they think about it in those terms even. They sort of they go along with it because it's probably just the water in which they swim, right? They're just used to it. If they're not policy minded and they're not like actively trying to think of new ways that the world could be, then they probably just accept it and they just think, oh, let me just focus on delivering the best care I can within these constraints, within these this confined space, because this is what my world is, and I didn't create this world. I'm trying to be a good nurse or a good doctor, right? So that's sort of like the clinician side. On the policy side, there's I think sometimes there isn't actually, I think, a lot of recognition. That's kind of kind of why I wanted to write that article. There is some recognition of the I think of the different payer types, and there's the cross-subsidization there. You can find articles about that. People debate that a lot. But I think there's kind of less and fewer articles, less discussion about the cross-subsidization across the departments. That's sort of why I like I said, I felt like that was a useful and helpful thing to shed some light on. And then, on the question of like, well, do they accept it? Do they approve of it? Well, if they're kind of not recognizing it necessarily, but they're complicit in keeping it going, which is frustrating. And certainly if you are defending certificate of need laws, or if you're defending bans on, against different organizations and different types of people being able to own different kinds of facilities, well, then sort of implicitly, whether you realize it or not, you're sort of defending that world, I think.
Yeah, and I think what's been most enlightening to me is that if you are a hospital that has to cross-subsidize because you have to take certain kinds of patients, and you have to just take whatever price Medicaid gives you. So you have to get the profits from somewhere else. We're not giving hospitals a lot of kind of leeway to maneuver. Is it then so surprising that they just fear competition, right? Because it's not like they're able to compete fairly in some sense, right? Like I could completely understand they might just object to the very notion of, let's say, a boutique physician-owned hospital, because, well, that hospital doesn't have to take certain patients; they can refuse them, and it's like, well, that just kind of like chips away at this balancing act that the hospitals have to do, right? But then what you do get is it, it changes the thinking of how hospitals operate, right? Like, instead of seeing competition as something that hospitals do like other businesses, it's the way that you do business is through seeking protections, like the ones you already mentioned, like certificate of need laws, stopping the expansion or the creation of physician-owned hospitals. But then also other things like, hospitals have facility fees, right? And if they can buy up private practices, they can apply those facility fees to those private practices, right? Because now they're part of the hospital system. You got the 340B program, right? Like, you have all these programs where hospitals can say, well, we need these because we can't compete. And in some sense, it's true that they can't compete, but it's not like it's because there's something inherently unprofitable about these patients or services. They provide a value, right? And we can think of other ways in which that value would be compensated, but they're kind of structurally not allowed to be compensated. And so I think that kind of creates this kind of like political monster almost, where, yeah, if I were a hospital, I mean, it's hard for me to imagine me not doing that. But then how do you actually kind of like break that cycle? It's and on on the one hand, uh, that's also why I don't really. It leaves me unsatisfied, the kind of state that this whole debate is in, where you have traditional hospitals that say like, oh, a physician-owned hospital will hurt my bottom line, and the physician-owned hospital will say like, well, no, we won't hurt it that much, you'll be okay. And they're just focusing on the bottom line, whereas I think the real question here is competition something that hospitals are even comfortable with, right? Or is it just so ingrained in them that they seek protection, that it's not about the numbers, it's about the mere fact that they feel like they have to compete, that feels threatening to them. And I think in order to really change that, you actually have to recognize that this whole kind of anti-competitive nature from hospitals comes from this model of cross-subsidization, because it is inherently kind of unstable, and so you need to have like non-market ways to stabilize it.
I agree. I think if you're kind of like, as you were getting to the, if you're just looking to see like what's the one next step, then you're going to be locked into, and you're sort of like saying, I'm not willing to dig a couple, levels down into like what's really causing this, etc. If you're not willing to take a step back a little bit, and you just want to know what's the next thing that I should either support or oppose, that's like immediately in front of me, then yeah, you get exactly this kind of debate that you see, and that happens all over the place. But we're trying to say, this is one of those issues where the real problem is three steps back, or at a kind of almost at like a different level, you can dig a little bit underneath this one, and ask and challenge some of those premises, and try to get to a better, almost like a better stance in which you can then maybe make some changes. And this isn't easy, right? I mean, because you're asking somebody to almost like hold off on the immediate like vote that's in front of them, right? Like this would be hard to do with legislators, right? Because they're in a committee hearing, they're being asked to cast a yes/no vote based on the piece of paper that's the thing that's actually written in front of them. they're not given a blank piece of paper saying, hey, can you design a better system, and can we work through this, and that is kind of like the think tank responsibility, and our goal here, right, is to sort of help change some of these conversations and point out some of the deeper flaws. Sometimes the piece of the proposal right in front of you is sort of like a purely good idea, and you can come out in favor of it, or if it's a very, very flawed idea that you definitely want to not see happen, you can criticize it and critique it, but directly. But this is one of those deeper things, and it comes down to that whole attitude toward competition. Hospitals just are not. They're thinking much more in terms of like protecting their turf. They'll think of patients and patient groups and patient populations, and I'm afraid that I don't think the population health movement has really helped in this regard. They think of patient populations as like their patients, and
Right.
and don't steal away my patients. Those were my patients. Well, just because you've seen this patient for the last 5 or 10 years doesn't make them forever yours. You should have to kind of compete to keep that. Other places have to compete to keep their customers. A couple of years ago, I switched from Starlink to a different type of internet provider. Right? Why? Well, Starlink was great for the time that I had it and for the several years that I had it, but then something better came along. It's made the switch, and it's why should Starlink be able to? I'm not accusing them of this, by the way. But I'm saying, like, why would they, if we were to superimpose like the healthcare mindset on this, why would they be able to like go to anybody and say, oh no, you're our customer, this neighborhood is our customer, and so we need a protection, or we need to keep out this competition. It's something better comes along, and they should be thinking in terms of like how can they compete, and sometimes that requires some policy changes, because the thing that's making it different is that they're hemmed in and by previous policy regimes, but that's just, again, the reason why we sometimes have to take a couple steps back.
Yeah, I think that point is interesting, because it puts a very different spin on this notion that, let's say, physician-owned hospitals are stealing patients. What does that mean? I mean, like, these patients have agency too, right? It's like, and it's not like the traditional hospital, the incumbent hospital, owns them somehow. So it's also very demeaning to patients themselves. And another element of this whole debate that I think is worth addressing is that what I'll often see in kind of like an attempt to make progress here is to kind of call hospitals hypocritical, and say, like, well, sure, maybe this rural hospital needs some protection, but you're a big hospital with lots of profits, and you're just using all these things in order to keep out competition, just so you can keep your higher profits. And again, I find that very dissatisfying, because even if that is true, we've encouraged hospitals not to be concerned about competition, right? Like, the kind of currency of the realm here is protection. So if you actually cared about this, you would want them to like earn their profits, right? But that's not the discussion that we see. So what are some ways that we can have like an alternative to the cross-subsidization model that could actually allow competition just to be part of the hospital market?
I think this is a tough one to unravel, is because like we've already made some societal kind of obligations out there. And once you do that, you have to either say, okay, well, are we going to either revisit those obligations about, for instance, like what we expect of an emergency department being open 24 hours a day, and that sort of things being, facilities being open in serving different, all different kinds of locales, right? Like rural hospitals, you often see those shut down or close down a service, and then there's a whole uproar about this. And you realize, well, should that have maybe ever, first of all, maybe it's okay, maybe it's the right thing for that thing to close or something, or should that have ever been open in the first place? Or maybe it's just this is the the come and go of things changing. I think there are some solutions that could be better, even if they're not ideal in the long term. If we're not willing to kind of question some of the services that are less profitable, right? But we insist that they stay open. Well, at least a sort of non-ideal, but maybe more honest way of squaring that is through direct subsidy, which might be some kind of government program. Now, we're always reluctant to recommend that, right? And like we don't recommend that lightly, but I think that kind of in recognition of how bad this problem is, like that the fact that we're even willing to like think about that as a possible solution kind of shows how serious of an issue we think this is. There could be different ways of doing that too. I mean, you could imagine like a very kind of centralized and big way of doing that, big government kind of way of doing that. I don't know if that's the greatest way. Maybe there are more like local ways of doing this. In an earlier draft, I don't think it made it into my final Law and Liberty article that I put out, but in an earlier draft, I actually mentioned like a city or municipal kind of tax. So like it would be almost like more honest. There is a big hospital in the town in which I live, and if you were to run a bunch of numbers and tell me that, okay, we did the financial analysis on this thing, and it turns out that every household is paying, I don't know, a couple $100, $400 per year in other ways, in like higher payments on other services that you're using the hospital for, and it's all going toward making up the loss that happens with keeping the ED open and everything. And if you just said, well, instead of having this whole kind of dishonest, non-transparent rigmarole of a system, what if we just like had a line item tax on your for me, I live in New Hampshire, so we're used to getting like a property tax statement from the town or the city, right? And if it just said like, oh, this is your hospital tax because you're living in this community, and we've made the obligation of having of an ED that has these features and all these capabilities and everything, and so your payment for that, you owe this program, this obligation, this much money. Would I love that? Maybe not, but it would be like a more honest way of doing that, honestly. And so things like that, and there, I think we'll be thinking about this issue and writing a lot more about it in the future. And there's bound to be other kinds of ways out of this kind of conundrum. It is a bit of a dilemma, and so the solutions aren't going to come easily, but I'm sure there are things that we could do that would be better than the status quo.
And what you're suggesting isn't that we take the system as it is and just add another tax to subsidize the hospital. No. It would be to have this subsidy funded through taxes replace things like the certificate of need ban, facility fees, bans on physician-owned hospitals, reforming 340B, all of those things that are being used by the hospital industry and various lobbying groups where they say like, oh, we need this. Well, we can basically tell them like, look, if you really need it, then like we are going to propose a direct subsidy. You can be held much more accountable in terms of your numbers that way, and you can't hold the whole kind of healthcare market hostage for that, which creates all sorts of perverse incentives. It makes things much more expensive, and so who knows, maybe even like a direct subsidy for certain services might end up saving us money because hospitals don't have to overcharge patients with commercial insurance, and it would just be a much more honest system, I think.
It would absolutely have to be as part of a deal, so to speak, like a major reform kind of deal. And again, it's we don't say this lightly because we know how easily that could be, how that could go politically wrong or not be implemented in a good way. But it sort of it's almost like the universal basic income kind of debate, like so against that on many levels. But when you say, well, what if you do it and you simultaneously roll back, all these other,
Everything.
it becomes at least rational to entertain, and you can have a thoughtful debate about it. Whether you still come out on against it or for it, that's almost a separate issue. If it's got to at least be, to even kind of have a decent discussion about it, it's got to at least be tailored and connected to these other reforms. That would be the only reason to do it, right? Because these other reforms really could represent a big gain, and in terms of just having, moving us toward a functional healthcare system, something that's not such a Rube Goldberg contraption, and let some of these other benefits accrue. Because markets can deliver, and they can deliver such wealth and prosperity, and you don't. There's almost like an extra cost over and above just the sheer numbers, and to having all of these kind of this complexity.
Yeah, and just put a final point on this, just to draw out what you're saying, Jared. Protectionism doesn't actually protect the thing that you care about, right? Like all these laws, all these programs that we use to prop up these services that are valuable, that we do need. Protectionism doesn't actually protect it. It just gives you the veneer of security. And instead what you get is inefficiencies and corruption, right? Like people can use the rhetoric of community need and the need for protection as a cover, and it doesn't really matter if they're using that cover to justify like an actually struggling community hospital or like a big profitable health system. The fact is that they feel compelled to do that anyway, and that's because we've structured things around them such that that's what they have to do, and there has to be another way. I think we'll leave it at that for now, and I would like to thank you, Jared, and thank our audience, and until next time. To stay up to date, subscribe to our show from whatever podcast platform you're listening from. To support our show and the Center for Modern Health, you can make a tax-deductible donation at centerformodernhealth.org/support. Thank you for listening.